accredited institute in Pakistan. That's an Aga Khan University Hospital. So after spending 1 year as a trainee technologist, then I have joined clinical biochemistry department as a medical technologist, and then spent a couple of years with them as an senior medical technologist. And then I have spent 7 years in Roche, because I have got an opportunity in 2007 as an application specialist. The 7 year span of in a Roche diagnostic, I was working as a product manager for centralized diagnostic between the duration of 2007 and 2013. And I have an overall 10. Then I got an opportunity in Abbott Diagnostic Division in Pakistan, because they were giving me a responsibility for application related and the NPS coordinator as an for the affiliates, Pakistan affiliates, which include Sri Lanka, Bangladesh, Maldives, and Afghanistan. So I have a more exposure in Abbott as compared to the Roche. So I switched from Roche to Abbott, and then I have spent 10 years in Abbott Diagnostic Division as an application manager, regional application manager for this. Since April 2023, I have got an opportunity in SNIPE Diagnostic as a training manager consultant. And my reporting is to Ziv and Zui. They are my team leader, because we are supposed to be reporting to a global support and training team. So if I would like to ask you, if anyone want to introduce themselves, you can introduce, please. Okay. So let's start with the presentation.
Recording in progress.
So I hope you can see my screen right now. So today we have a presentation in which we have the topic is thyroid panel. So let's start. In this presentation, we have a 4-part. The first part contains a thyroid gland introduction and the thyroid systems, which including the HPT axis and the biosynthesis and the physiology of the thyroid glands. And then in the second part, we will discuss about the clinical utilization or application in different clinical condition and thyroid-related diseases and the market that way can be used in this clinical applications. So the third part, what is the solution which is provided by the SNIPE for the thyroid dysfunctions, and then there are different conditions of thyroid, and especially in the thyroid carcinoma conditions, what panels can be used for the clinical correlation, for the disease management, and even for the prognosis of the disease. And the last part, which contains some marketing information, like what is the global prevalence of hypothyroidism and hyperthyroidism, and in how many countries usually the markets is using the assays for that. So let's start with the So let's start with the introduction. So as you know, the thyroid gland, basically, if you go to the, so you see that the thyroid gland is basically in a small gland, which is in a butterfly loop-like structure of around 2 inches. That lies just the larynx and the trachea, between the larynx and the trachea. and it's in a skin below that. That's also called an Adam's apples in the neck. So this is basically in a structure of the thyroid. In the front structure, then the back structure. In the back structure, there is a small area which is called a parathyroid glands. So these thyroid gland secretes major three hormones. And as you know that the two thyroid hormones which are called T3 and T4, and the basic name of T3 is triiodothyronine and T4 is thyroxine, and the calcitonin. All these three hormones are released by the thyroid glands and to maintain and regulate the thyroid glands function. So if we go to the next slide, we can see there the HPTH axis. So what is HPTH axis? This is the hypothalamus pituitary thyroid axis, in which a thyroid gland produce the hormones which is our T3 and T4s, in which the almost 20% of T3 is converted into a T4, which 100%, which is 100%, and then 5% of reverse T3 is converted into the 100% of T4. So this is all about the thyroid, hypothalamus, pituitary thyroid hormones. Thyroid axis. And then if we talk about the overall mechanism, in this mechanism you can see that the basically, if you see that this is based on a negative feedback mechanism. In this thyroid hormone regulation in the hypothalamus HPTH axis, there is an involvement of hypothalamus, which has a pituitary gland which receive the thyrotropin releasing hormone, and this hormone stimulate the TSH to act on a thyroid glands, and then thyroid glands release the T3 and T4 hormones, which basically increase the metabolism and the growth and development and the catecholamine effect of increasing effect of this catecholamine. On the basis of the negative feedback mechanisms, and then again it's stopped the process of releasing of thyrotropin releasing hormone, and then the stimulation of thyroid stimulating hormone is stopped, and then the production of thyroid hormones is stopped during this HPT axis process. So if we talk about more, let's talk about in the next slides the hormones productions. If we talk about the hormones production, you know that the thyroid gland secretes thyroid hormone, which is thyroxine and triiodothyronine, which basically regulate the metabolism, oxygen consumption of cells, cholesterol level, growth, and development in the children. When the body requires the thyroid hormones, the pituitary secretes the TSH, which stimulate the thyroid to convert the thyroglobulin into the active hormones. So if we talk about the thyroid physiological feedback, it's based on a negative feedback mechanism. And so the thyroid gland produce of the body T4 and about 20% of its T3, and iodine is essential for this thyroid hormones production. So if you see here in to the colloidals of the thyroid follicles, if we select this, you can see this is area of thyroid follicles, colloidals, that's through which the iodine is transported by the penderin to the colloidals of the thyroid follicles, where the iodine is oxidized to iodine. Iodide is oxidized to iodine by the TPO, which is a thyroid peroxidase. And then this thyroid peroxidase further catalyzes the iodination, which attach one or two iodine to tyrosine residue of thyroglobulin. So then they form MIT and DITs, monoiodothyronine or thyroglobulin and diiodothyroglobulin. So the triiodothyronine and thyroxines are subsequently produced by the coupling of one DIT with one MIT. If the one DIT combined with the one MIT, it's produce the triiodothyronine, that's the T3, or if the one MIT here. So if the one MIT and two DITs combines, and they produce the thyroxine or tetrahydrothyronine. So the overall follicular cells basically reabsorbs and hydrolyze the thyroglobulins, and after reabsorption of the thyroglobulins, it's release the free T3 and T4, which eventually enters in the bloodstream for the circulation and the regulation of the different body metabolisms. So if we go to the next introduction on the physiology of the thyroid, you can see that the thyroid first physiology is related to related to that, this is in hormones and using during the development of the mammalian's brain, it's enacting as a migration and the differentiation of the neural cells, synaptogenesis and myelinations. So this is the major first function of the thyroid physiology, and along with that, they also produce the T3 and T4, which play a very very vital role in the metabolic hormones because their level influence the body metabolic rate, and then the amount of the energy utilized by the body at the rest condition is also produced by the metabolism of this T3 and T4s. Along with that, the other major physiological function of this thyroid gland is when T3 and T4 are bind and their intracellular receptors located on the mitochondria, they cause an increase in the nutrients breakdowns and the use of oxygen to produce the ATP. These are the three major functions and the physiological functions of the thyroid gland. So if we talk about the clinical application and utilization, in which we will cover about the clinical conditions. So as you know that if we classify the thyroid diseases, so the more than 99% or about around 99% thyroid diseases are called primary thyroid diseases. Only the 1% almost are considered as a secondary thyroid diseases. So let's talk about the primary thyroid diseases that can be classified into two types. One is called an autoimmune disease, and the second one is called non-autoimmune disease. So if we talk about the autoimmune disease, these are majority 80% belongs to the primary thyroid, and just the 20% are the non-autoimmune disease. If we talk about the major part of the primary thyroid disease, it includes the autoimmune disease in which the human body produce self antibodies against any organs or tissues or some hormones. So that's called an autoimmune disease, in which the Hashimoto thyroiditis, the Graves' disease, these are the two examples of autoimmune disease in which one case belongs to the hypothyroidism and the second Graves' disease belongs to the hyperthyroidism. So this hypothyroidism and hyperthyroidism thyroid dysfunction belongs to the thyroid panel, which includes the TSH and T3, T4 values. So the thyroid stimulating hormones, if the values is increased and T3, T4 are usually decreased, we call them hypothyroidism. If TSH value is decreased and T3, T4 values are increased, we usually call them hyperthyroidism. So if we talk about 20% non-autoimmune disease, which are related to the some old age factors and some aging factors or some inherited factors. So these are called thyroid goiters. So other type is subclinical thyroiditis. That's an inflammation of thyroid gland is called thyroiditis. So the last option, which is non-autoimmune in the primary thyroid disease, is a thyroid carcinoma or thyroid cancers. So this is the generalized classification for the thyroid. So if we talk about more, the primary thyroid diseases, yes, the hyperthyroidism, the best example is a Graves' disease. This is basically a toxic diffuse goiter. In this Graves' disease, basically a toxic multinodular goiter or maybe a toxic adenoma, are the condition in which it leads to the diagnosis of the hyperthyroidism. If we talk about the hypothyroidism due to the iodine deficiency, an autoimmune disease of Hashimoto thyroiditis, that's a condition which is called an hypothyroidism, in which if we just consider about the TSH value, TSH value is raised, and usually the T3 and T4 values are decreased. So if we talk about the hyperthyroidism, in this hyperthyroidism, it is usually observed that the TSH value is low, and usually the T3, T4 values are high. So if we talk about the thyroid cancers, cannot be ruled out with the routine testing. Specialized testings are required. So we will discuss in the slides about this. So if we talk about the hyperthyroidism, so hyperthyroidism means the excessive concentration of thyroid hormones in tissues. So the what excessive concentration of thyroid hormones, as you know that the thyroid hormones are T3 and T4, right? So if the T3, T4s are raised, usually the TSH are low. So this excessive concentration of T3, T4 means it leads to the hyperthyroidism and the vice versa with the hypothyroidism. So what are the clinical symptoms of hyperthyroidism? Basically, it's in a normal size is this, but due to this hyperthyroidism, increased T3 and T4 serum values, the size of the thyroid gland increase, and it looks like a condition which is called a goiter. And all other symptoms along with that symptoms, typical symptoms, there are a few more symptoms which leads towards the diagnosis of hyperthyroidism, which is an sweating, which is more than a normal weight loss. And in the women's, it's an irregular menstrual cycle, the high blood pressure, and the bowel movement in the normal diarrheas and prominent eyes. So these are the typical factors of hyperthyroidism. So if we talk about more, so let's go to the next slide. That's the Graves' disease. So basically, the Graves' disease is a TSH receptors. You know that this play a very vital role in this thyroid cells metabolism process controlling. And you know that the TSH receptors also can interact with the TSH and autoantibodies against the TSH receptors. So if we talk about the epidemiologically, the global distribution in that disease is a very common cause of hyperthyroidism. Almost 80% of the hyperthyroidism case belongs to the Graves' disease, and with an annual incidence of 20 to 50 cases per 100,000 person which are having a clinical finding of thyroid dysfunction. So if we talk about the risk population, between the age of 30 to 50 age, it's a high risk for hyperthyroidism, that's in Graves' disease, and the life risk is 3% for the woman and 0.5% for the men. And the serological testing that can help to diagnose the Graves' disease is established based on the clinical features of T3, T4, and TSH. In certain cases, if the additional testing is required, which is called thyroid antibodies testing, TRABs. So if we talk about the thyroid antibodies receptors testing and how this autoimmune disease of the Graves' disease is progress, that's a process that the pituitary glands, which is the major functions to thyroid receptor stimulating hormone, and then the release stimulate the thyroid stimulating hormone, and this thyroid stimulating hormones attach with the receptors on a thyroid cells and then stimulate the thyroid hormones to produce or synthesize the or regulation of the production of thyroid hormone, that's on T3 and T4. And this negative feedback control mechanisms cause the stopping of the pituitary gland to release TRSH, and then this TRSH stop the releasing of TSH, and then the process stops here. But in the this Graves' disease, what happened? The body produced the autoantibodies. That's why we call them autoimmune disease. And this autoimmune disease, this thyroid receptors antibodies are produced. This is malfunctioning of the immune systems. Due to this attach with the thyroid stimulating hormones receptors, and then they stimulate the hormones synthesis, and then the unregulated and then overproduction of thyroid hormones occurs, and then this overproduction stop the release of TSH, but the T3 and T4s are increased. So gradually TSH values will reduce in normal this hyperthyroidism case, but usually it's maybe some cases the TSH remains normal, but the T3, T4s are high in this typical hyperthyroidism case. If you have any question, you can ask me or you can stop me, right? So if we talk about the multinodular goiter, so you can see that this is the best example of a multinodular goiter. So basically, it's an modular goiter, which is a typical example of hyperthyroidism, in which there is an excess production of thyroid hormones from the thyroid nodules. So this thyroid nodules are doing an overproduction, which is not stimulated by the TSH due to the Graves' disease condition. And this is the second most cause of the hyperthyroidism is developed in the world, in the developed world. So this is about toxic multinodular goiter. And if we talk about more, the toxic adenoma, the histopathological scannings you can see here. There are some slides which shows you the common type of hyperthyroidism, which is a toxic adenoma. That's basically inflammation of the glands, and which is caused by the autonomous tumors of the thyroid glands, which produce the excessive thyroid hormones. So if we talk about more, then we have a typical example of hypothyroidism. So as we know that in the hypothyroidism, there are some definition, which means there's a common condition in which the thyroid hormone deficiency, which thyroid hormone deficiency, T3 and the T4. So they, if the values are reduced in the bloodstream, it means there is a typical example of hypothyroidism or subclinical hypothyroidism. If the TSH in a correlation, it's called a typical hypothyroidism, or otherwise it's called subclinical. So the basic clinical symptoms of the hypothyroidisms have a higher prevalence of cardiovascular risk factors, which is an early alarming sign for the patient who have an geriatric age and have some cardiovascular risk factors, so that they need to be monitored their hypothyroidism condition and the treatment and the prognosis, along with the cardiovascular risk assessment. It's also including the hypertension, increased waist circumference. Along with that, there are some other clinical hypothyroidism symptoms like the enlarged thyroid, maybe heart rate is slow, and then some cases the GIT disturbs with the constipations, and then appetite is reduced, and along with that, infertility, heavy menstrual cycles, and then tunnel syndromes. And they are typical case in which the thyroid gland does not produce the enough thyroid hormones, and the in typical case, that's in weight gains and the memory loss, along with the intolerance of cold feelings of the tiredness. This is a typical example of hypothyroidism. So if we go to the more about the Hashimoto's thyroiditis, Hashimoto thyroiditis is basically an autoimmune disease. In this disease, the thyroid cells are destroyed, by the cells, and an auto antibodies mediated immune process occurs. And this epidemiologically is a global distribution is after the age 6. Hashimoto is the most common cause, and then hypothyroidism in the United States and those areas where world iodine intake is inadequate. So the Hashimoto disease, the root cause is then an iodine level decrease in the bloodstreams, and then that's lead to the one of the major cause for this autoimmune disease. The incidence is almost a 3.5% in 1,000 per year in the woman and 0.8% per year in the men. So the women are more prone to this autoimmune disease of Hashimoto thyroiditis as compared to the men. The overall laboratory findings play a very vital role to diagnose this autoimmune disease of Hashimoto thyroiditis. Is an TSH and T4 levels coupled with the anti-TPO antibodies will help us to diagnose the Hashimoto thyroiditis. So if we talk about more, what are the clinical typical examples? Usually, if the TSH value may be high or normal in Hashimoto thyroiditis, and the FT4 is normal or low, FT3, T4, and T3 are normal or low, along with the anti-TPO is high, anti-TGO is high, and anti-TSHR is normal. So these are the clinical typical finding of Hashimoto thyroiditis. Along in this test, according to the American Thyroid Association and the American Association for the Clinical Endocrinologist, ranging from after every 5 years to individual above age 35, they have to check the periodically, even at the age above 60, the screening of these assays to rule out the Hashimoto thyroiditis. So if we talk about the carcinoma, which is specialized related to the thyroid cancer, there are different types of thyroid cancers, which include the papillary and the non-mixed papillary follicular thyroid cancers. So the papillary or mixed papillary and follicular thyroid cancer is almost 85%. That's in a follicular, and the Hurtle cells thyroid cancer is a 10%, while the medullary thyroid cancer prevalence is 3% among the thyroid cancer, or anaplastic thyroid cancers prevalence is almost 1%. So if we talk about the risk population, thyroid cancers can be occurs at any stage or at any age, but above 2/3 of the all cases found in the people age between the 20 to 55 years, and then women are diagnosed with 3 of every 4 thyroid cancer cases. So the women are more prone to the thyroid cancers as compared to the men, and they have risk factors, which is in a low iodine diet, which may lead to the thyroid cancers. So the another risk factor is the radiation exposure, and then genetic feedback or a genetic history of having a thyroid carcinoma. That's why they have a risk population. If we talk about the survival rate of thyroid cancer on the basis of different types like papillary, follicular, medullary, or anaplastic thyroid cancers, if the cancer is located only in the thyroid, about 2/3 of the cases are diagnosed at this stages. The 5-year survival rate is 99% in the papillary, follicular, and medullary thyroid cancers. So for the localized anaplastic thyroid cancers, the 5-year survival rate is 30%. So the treatment of this thyroid cancer is usually the surgery, removal of thyroid glands, or the hormones treatment. Levothyroxine is another treatment for the management of thyroid carcinoma, or a radioactive iodine, the radioiodine therapy, which may help some patient for the thyroid carcinoma treatment, along with the chemotherapy and the targeted therapy may help to enhance the survival rate of such patients. So if we talk about the diagnosis, in the diagnosis of thyroiditis and then hypo and hypercasis, there are some clinical symptoms. Along with that, the physician refer to some lab test. So the normally serological testing, routine testing is called a thyroid function test, which include TSH, thyroid stimulating hormone, tetraiodothyroxine, or tetraiodothyronine, or a thyroxine, along with the free T4, triiodothyronine, and the free triiodothyronine. So these are the journal thyroid function test, along with the supplemental testing of thyroglobulin, TG, anti-TG or thyroglobulin antibodies, thyroid peroxidase antibodies, thyroid antibodies, TMAs, the reverse T3, anti-uptakes. These are the specialized or supplemental testing to differentiate between the further autoimmune diseases and as well as the other subclinical and the clinical conditions. So if you want to differentiate between a Graves' disease and a Hashimoto disease, just for your interest, the TSH is low in the Graves' disease, while in the Hashimoto's disease, TSH may be normal or the raised. So if we talk about the T4 and T3 in Graves' disease, the T3, T4 is high, while in the Hashimoto's thyroiditis, the T3, T4 is low or normal. And on the basis of anti-TSHR, so this is the marker, anti-TSHR, on the basis of this thyroid hormone receptors antibodies testing, they can differentiate with the Graves' disease along with the T3, T4, and TSH to rule out between the Graves' disease and Hashimoto's disease. So the other procedures for the clinical diagnosis are the nuclear medicine for the treatment, the thyroid radioactive iodine uptakes and then screening and also if the nodules are present, so the immunological or radiological imaging helps them to diagnose that thyroid disease, and the biopsy also will help us to provide evidence of on the basis of histopathological testing to rule out the thyroid disease. So if we talk about the thyroid radioiodine uptakes and the scanning, that's usually called a thallium test. It is used to before the radioiodine treatment. So you can have 5 different scintigram. You can see that in the bottom that the patient have a different syndromes. Mark were 99 TC. So you can see that this is A. This is the normal thyroid. But in the Graves' disease, the radiological imaging of after taking the radioiodine treatment or taking a radioactive iodine, that's in a Graves' disease in which diffuse increased uptake in the both thyroid nodules as compared to the normal thyroids. So if we talk about the C picture, this is the Plumber disease in which the thyroid gland diffusion occurs, and then the thyroglobulins are a specific marker for this Plumber disease. And then this is an adenoma condition, which is due to some toxic adenoma or some mechanical adenoma due to the occurrence which the inflammation occurs in the thyroid glands. So due to the thyroiditis, the inflammation of the thyroid glands, this is a typical picture of the scan picture of this disease. And then on the basis of radiological imaging, they can diagnose this different condition of the patient. So let's talk about the solution that which are provided by the SNIPE for the thyroid panels. So in the routine testing, we have a first test is a thyroid stimulating hormones. So basically, it can maintains the amount of T3, T4s and the negative feedback mechanisms in the blood, which helps to maintain the T3, T4 and the TSH assay mechanisms. So it basically controls the utilization of the energy. When the second test is thyroid profile. So the T4. So thyroxine is basically a main product of the thyroid, and its regulation is controlled by the TSH. And most of the T4 in the serums are bound with the TBG. So if we talk about the TBG, and you know that the TBG is a play a very vital role in this thyroid mechanism, and it's also regulate the through the negative feedback mechanisms. So if we talk about the free T4 is basically a physiological active form of the T4. And if we talk about the T3, it's an important hormone which is for the thyroxine effect. It's a very target organ. So most of the T3 in serums are bound with the thyroid binding globulins. If you talk about the FT3, this is a free triiodothyronine, which is basically a physiological active form of T3, and very sensitive for the diagnosis of hyperthyroidism, especially with the T3 hyperthyroidism. So as you know that in especially the T3 hyperthyroidism, the thyroid profile case is the TSH is low, and the FT4 and FT3 they may be inversely relation. If the FT4 is low, the FT3 may be raised, and the T4 may be normal or low, and the T3 will be high. So, but if we talk about the anti-TPO, anti-TG, and anti-TSHR, they will remain normal in the typical T3 hyperthyroidism case. So these are the routine testing. What are the solutions which are provided by the SNI from their platforms, and what is the clinical related interpretation? So we classify the thyroid panel disease into the hyperthyroidism and hypothyroidism. So you have to think with the hyper means increase and hypo means low. So the hyper in the hyper case and the hypo case, there will be low and high value of thyroid hormones. So if we talk about the T3 and T4, you can see that in the hyper case, the T3, T4 are raised. And usually the TSH are low in primary hyperthyroidism cases. But in some cases of hyperthyroidism, subclinical hyperthyroidism, the TSH is low, but T3, T4 remains normal. So if we talk about the hypothyroidism case, in which the thyroid hormones, typically the T3, T4 levels are low, usually the TSH is high. But in some cases of subclinical hypothyroidism, the TSH is high, but the T4 and T3 value remains normal along with the FT4 and FT3. So this is called an subclinical hyperthyroidism or hypothyroidism as compared to the primary hyperthyroidism and hypothyroidism. So if we talk about more about secondary hyperthyroidism, in the secondary hyperthyroidism, you can see that the TSH levels are raised along with the T3 and T4 and the FT4 and FT3. This is called secondary hyperthyroidism. If we talk about the secondary hypothyroidism, in which all the markers, including the TSH, T4, T3, FT4, and FT3, are lower than the normal ranges. That's why we call them a secondary hypothyroidism disease condition. If we talk about the T4 thyroid toxicosis, in which the TSH is low and the T4 and the FT4 is high. If the TSH is low, only the T3 and FT3 is high, they call them T3 thyrotoxicosis. So if you have any question, you can ask, or so do you have any question? Hello? Okay, so this is an untypical condition in which hypo, primary, secondary, and subclinical disease classification on the basis of thyroid testing, and the thyrotoxicosis on the basis of T3, T4 results interpretation is explained. So if you go to the next slide, you can see that the SNIPE given a very comprehensive solution for thyroid panel. As you know that our thyroid panels are FDA approved. So the TSH, which got the FDA clearance in 2017, and the routine T3, T4, FT4, and FT3, they have been cleared from the FDA in 2018. So as you know that for the American market, if you have an FDA approval, you can use that product in USA market, but for the rest of the world, we have a CE mark product. So usually the globally in the European market, in the Asian market, in the Russian market, you may be required a CE certification rather than the FDA. But if you have an FDA, the so-called American Association for the basically accreditation, the Federal Drugs and Food and Drug Regulatory Authority in USA, if they give a certification or the notification for their acknowledgement for the registration of that product, and then this is basically FDA approved product. Here they can be used in the US market. So if we talk about the technical information, so you know that we have two generation as of today, the first generation and then second generation thyroid profile assays. So if we talk about the number of tests, this is an complex and a very flexible option that we have 100 test and 50 test pack size, along with the optional free calibrators and control. And then we have a principle of sandwich in TSH, while the T4, FT4, T3, and FT3 assays are based on the competitive principle. All the assays have a sample type recommendation. The first generation was serum, and the sample volume varies from the 40 microliter to the 100 microliter. And yes, we, on the basis of the results accuracy and reliability, we have a traceability for the WHO third international standard 81 by 565 for the TSH, then USP standardization for rest of T3, T4, FT4, and FT3 panels. If we talk about the calibration interval, the guidelines for the calibration frequency is 2 weeks for the TSH and 1 week for each analyte T4, FT4, T3, and FT3. And if we talk about the calibrators and control, we are providing free of cost calibrate and control. Along with that, we have a reference ranges of 0.3 to 4.5 in TSH, along with the T4 of 52 to 127, 8.9, 17.2, and then T3 0.69, 2.15, and the FT3 2.0 and 4.2 picogram per ml. So if we talk about the linearity, as you know that the linearity is basically the lowest and highest detection limit. So the TSH, we have a very comprehensive less than 0.001 micro IU per ml to up to the 100 micro IU per ml. If the customers or the patient or a physician need a exact value for the utilization of TSH assays and prognosis markers, so the automatic dilution is available on our all analyzer across the board of M series and X series. And the T4 values is relatively high. That's in 300 nanogram per ml, and in 120 for FT4, T3 is 10 and 50 picogram per ml. So overall test time was varies from the 20 minutes to the 35 minutes, and the limit of detection is 0.006 and 1.5, which is clinically important in the package insert according to the guidelines it's given. So then we have a second generation. There's an improvement in the second generation kit, that in a few parameters we have and both sample types validated on our assay. like TSH, we are both recommended serum in plasma. The sample volume is also different for the TSH and T4 molecule, and then we have traceability according to the global guidelines. And we also improve the calibration interval. So before that, that was in a 2 weeks or 1 week's calibration frequency. But in the second generation, we have improved the TSH stability. And if you talk about the reference ranges, linearity, and the limit of detection, which is also improved in these assays. So you can see here that we have an improved version of second generation of thyroid profile testing in this profile. So if we compare the SNIPE thyroid panel, especially the TSH, thyroid stimulating hormone, with other commercially available assays, you can see here we have a regression value of 0.95. And in the FT4 case, we have a regression value of 0.997 with the other commercially available FT4 and the TSH assays, which shows an excellent correlation between the other competitors in the market for the TSH and FT4. We are equally good in thyroid panels of our from the Meglumi platform. Other than this routine testing, we have a thyroid supplemental testing of thyroglobulin antibodies, anti-TPO, anti-TMA, TMAs, thyroid antibodies, and reverse T3. So if we talk about the competitors, what are the other players which are providing thyroid supplemental testing? So you can see here, for the supplemental testing, we have Roche, Abbott, and Siemens. So if we talk about the menu, we have a specialized menu of TMA and R reverse T3, which are not offered by the Roche, neither the Abbott and the Siemens. So this is the key differentiators in thyroid panels, that we have two specialized parameters for the diagnosis of thyroid dysfunction. The Roche, Abbott, and Siemens does not have. The second challenge of competitors, they have a Siemens. They do not have this solution from the single platform. So they are offering thyroid antibodies from Emulite platforms, and the TGA and NTTP for Advia Centaurs, and from the other platform they have a different solution. So they have a different analyzers like Emulite 2K, Emulite 1000, Advia Centaur, Atlica, and then 4 or 5 analyzers need to be placed in the same premises to perform all these. But the SNIPE is the only company who gives the across the board, either the M series or X series. They are given a solution for the niche parameters like TMAR, reverse T3, which we do not have any other competitors. And especially for the routine parameters like thyroid antibodies, the Siemens has a big this challenge. If we talk about the Abbott hasn't provided a solution, but they are missing assays of TMAs and reverse T3, along with the Roche and the Beckman Coulters and the Biomurics assays are less than even with the Abbott and Roche and Siemens. So this is the market positioning of SNIPE analytes. If we talk about the thyroglobulins, so as you know that this thyroglobulin is a dimeric protein, which is basically produced by the thyroid gland to make the hormones. It acts as a substrate to synthesize T3 and T4, which is a storage of the inactive form of thyroid hormones and iodine. So you can see here that the iodine plus thyroglobulins bind with them, and then it's produced monoiodothyronine and diiodothyronine, and then it's later biosynthesis of T3 and T4 is occurs when the 2-DIT and 1-MIT combines produce the T4 with the help of TP cycle. So if we talk about more about the thyroid introduction, it is considered to be a special marker for the integrity of thyroid glands. If the thyroid follicles was lost, then the large number of thyroglobulin secreted in the blood. So this carcinoma condition can be ruled out by using the routine thyroid testing along with the thyroglobulin testing. So the monitoring treatment of the thyroid cancers and to detect the recurrence is most important part, and the serum level of thyroglobulins, which may be dropped to very low or undetectable after total and the non-total thyroidectomy, that's a removal of this thyroid glands, and then successful radioiodine ablations of the residual thyroid tissues to treat the thyroid carcinoma. So the elevated thyroglobulins concentration is also reported in different thyroid conditions like autoimmune disease of the Graves' disease, Hashimoto, thyroid adenoma, and then thyroid carcinomas is also reported. And it's also used in the infant to evaluate the congenital hypothyroidism. So this is the clinical utilization of thyroid glands in neonates and also in some autoimmune disease, and also if the thyroidectomy has been done. So just to monitor the successful radioiodine ablation for the residual thyroid glands. So according to the American Thyroid Association Management and the guidelines of 2015 for the adult patient with the thyroid nodules and the differentiated thyroid cancers. So this is an initial follow-ups. It has been reported that the serum thyroglobulins or thyroglobulin should be measured every 6 to 12 months, and the thyroglobulin measurement may be appropriate for the ATA high-risk patients. So the American Thyroid Association's high-risk patient, if the patient is a high risk, their monitoring of thyroglobulins will help us to diagnose the differentiated thyroid cancers or a thyroid nodule. So if the patient needs some more confirmation, then they go for some other guidelines like the post-surgery clinical management of the high risk of differential thyroid conditions, in which the patient can be diagnosed with a different condition of the DTC. So like if you talk about the serum thyroglobulin measurement in the monitoring of the DTC patients with the time after the thyroidectomy, you can see here the thyroxine is off and the blood sample for the thyroglobulin measurement with an RAI administration is required. After 5 days, from day 6 to 12, a negative post-treatment of RAI when body scan is required, and after 6 to 12 months, the RH-TSH thyroglobulin testing and RIA diagnosis will help you to diagnose the successful of the treatment, or the further workup is required if the positive ultrasound for the WBS and then the TG values is exist. So the further workup or the treatment is required. So if the RTSH testing and then RI diagnosis WBC is negative or less than 1 microgram per thyroglobulin RSH value is there, so they need to be checked after every 12 months and a clinical examination, including the neck ultrasound or the T4 and HS thyroglobulin is required to manage the high risk DTC patient. So if we compare the SNP thyroglobulin, okay, so you have a question. Is there a single file with the time of receipt of results for all tests? Yes, I have one single file with the time of receipt of results for all tests. So in my opinion, you need a one screenshot for all testing, including the routine testing and specialized testing for rule out a different disease. Yes, I have it. I will share with you at the end of the session. So So if we talk about the SNP thyroglobulin assay of the first generation, the Roche Alexis thyroglobulin second generation, and the Bachmann thyroglobulin second generation. So we have a flexibility of 100 tests and 50 tests, while the Roche does not exist the less than 100 test pack size, but the Bachmann thyroglobulin pack size is 100 tests, but the per kit test is a 50 test. So if the customers want to buy the Bachmann kit, they need to buy 100 tests, and then they can put the reagent 50 test pack on the reagent area, and then but we have an 50 test pack size and 100 test pack size, which is available individually for the assays. So if we talk about the sandwich assays, our assays principle is based on the sandwich as compared to the Roche and Beckman. They have also a sandwich technique for the assay detection. We have a recommendation of serum, while the Roche and Beckman, they both have a recommendation of serum and plasma. But in the next generation of SNP thyroglobulin, we have a recommendation for both serum and plasma. If we talk about the sample volume, we have a lower sample volume required as compared to the Roche and Beckman. If we talk about the calibration interval, we have a 14 days onboard stability, while the Beckman thyroglobulin Roche has in 7 days, and the Beckman thyroglobulin is 56 days. We have a free calibrators and control by if the customer want to use a thyroglobulin from the Roche and the Backman platform, they need to purchase additional calibrator and control with them. We have an equally good reference ranges along with the linear range of 0.1 to 1000 nanogram per ml, which is higher than the Roche Alexis thyroglobulin and the Beckman thyroglobulin. If we talk about the test time, we have a just 29 minutes assay as compared to the Roche is offering an 18 minutes assay, and the limit of blank and limit of detection, we have an 0.1, while the Roche has a 0.02, but it depends upon the clinical utilization of limit of detection at the lower side. Is how much is clinical significant. If we talk about the traceability and the accuracy of the results performance, our SNP thyroglobulin first generation assay is standardized against the material BCR-457 for the internal reference and material measurement RMMS, as same as that the Roche and the Beckman thyroglobulins are offering about the traceability of the analyte. If you give me a 1 minute, so I have to take a one picture because it's a requirement in the training session. Just give me a 1 minute. Any question? If you have any question, you can ask. Okay, so your question is, where is Mindray? So we are not considering Mindray is our competitors, because no doubt the Mindray is in China, is a bigger company than the Snipe, but in immunoassay, the Snipe is an emerging leader in the immunoassay market. First thing. The second thing is the Mindray shares more in the radiology and imaging segment as compared to the immunoassay and chemistry, and they are more focusing on the hematology analyzers. The third point is, according to the 2022 CAGR, the Mindray growth rate is 17%, CAGR is 17%, while the Snipe CAGR is 23%, which is much higher than the Mindray. So we are an emerging leader in the immunoassay market, and we have a goal of more than 250 analytes by the end of this year. And as of today, because you have a feedback of 211 analytes available from the Snipe platform, but the last update is, as of today, we have a 235 analytes available from the Snipe platforms. So we are not considering Mindray as our competitors. We are considering the leading brand. Like if we talk about the Roche, according to the core diagnostic feedback of 2021, the global IVD market of the core diagnostic share, number one company is Roche, which has a 23.1% market share, along with the followed by the Abbott, which has a 16.5% market share, and then followed by the Siemens Healthineers, which has an around 8 or 9%, and then followed by the Danaher company, Beckman company. So we are considering Roche, Abbott, and Beckman as a competitor of the Snipe, not the other companies. I hope my answer will satisfy your expectation. So if we talk about the second generation, in the second generation, we have improved sample type, which is serum and plasma, which were only valid. The first generation was only validated on the serum, but the second generation of thyroglobulin is available for serum and plasma, and the calibration in sample volume is also improved as compared to the competitor of 35 and 40 microliters. Calibration onboard stability is enhanced in the second generation. Along with that, the routine calibrator and controls free of cost available. We have also introduced the limit of blank, limit of detection, which is equally good to the Roche parameters, and our assay time is 29 minutes. And the traceability is according to the certified reference material of 457 of the Community Bureau of the Reference, which is equally good. So our assay traceability, which gives the results reliability and the accuracy, is equally good as compared to the Roche and the Beckman in case of thyroglobulin. So this is about the comparison of Snipe thyroglobulin. We share with you, if we compare between the thyroglobulin first and second generation, you can see that we have an improved our product in terms of sample type. The sample type is improved. And if we talk about the calibration interval, we have an improved calibration interval. The onboard stability is enhanced, along with the reference ranges is reevaluated, and then on the basis of the linearity range, we have an edge over the competitors. The test time is 29 minutes, along with the limit of blank, which is improved with the limit of detection. So this is all about the difference between the Snipe first generation and the second generation kit of thyroglobulin. So if we talk about the next panel is thyroglobulin and autoantibodies. So in some cases, some have written that this analyte as A dash TG. This stands for thyroglobulin antibodies. So basically, thyroid globulin is a potentially autoantibodies and which enters into the blood, and it can stimulate the body to produce thyroglobulin antibodies. So the thyroglobulin, when it's enter the blood, it can stimulate the bodies. And then the monitoring of the treatment of thyroid cancer and to detect the recurrence is the major key factor for this thyroglobulin antibodies testing. And this thyroglobulin antibodies is also helpful for the autoimmune disease diagnosis, along with the monitoring of the Hashimoto's and Graves' disease, and for the differential diagnosis of the suspected autoimmune disease with the negative anti-TPO test results. If you want to have a look for thyroid testing of this thyroglobulin result, in basically the euthyroidism case in which everything is normal, the anti-TG or thyroglobulin antibodies remains normal. But if we talk about the hypothyroidism cases, it's maybe anti-TG increase or normal, or in case of hyperthyroidism, it's also gives you the high value of anti-TG. So if we talk about the Graves' disease and Hashimoto disease, especially related to the anti-TG, in this cases, it's a typical picture of so if we talk about the Graves' disease and Hashimoto disease, in a typical picture of anti-TG is a normal to the elevated value in both cases. On the basis of anti-TSHR or anti-TPO test, the results can be differentiated on the basis of Graves' disease. In some cases, anti-TSH in the Graves' disease is elevated, but in Hashimoto disease, if the anti-TG is normal or elevated and the clinical symptoms belongs to the Hashimoto thyroiditis, its anti-TSH should be normal. So this is a typical correlation of routine thyroid testing in hypo and hyper subclinical primary and secondary differentiation, along with the autoimmune disease of Graves and Hashimoto's. So it's play a very vital role for the diagnosis of autoimmune disease in patient. So if you go to the next slides, these are the few monitor treatment of the thyroid cancers and to detect the recurrence. As you know, the thyroid after the treatment, it's the monitoring is more critical and more important for the prognosis of the disease and the treatment response time. These tests can be used as a prognosis marker for some thyroid cancer diseases. So according to the NCCN guidelines version and thyroid carcinoma, papillary carcinoma guidelines, these are the few guidelines which are recommended. Like after 6 to 12 weeks of the post thyroidectomy, the removal of thyroid glands, there are some treatments, and then this is you need to recommend some steps to measure the thyroid BD uptakes, and then you have to check the thyroglobulin level if it's in less than 1 nanograms with the negative anti-TG antibodies. This then follow without RAN ablation or without RA ablation, and then if the suspected has proved that the thyroid, they need to adjuvant the therapy and the post-treatment imaging of the radiological image of the scan is required, then suspected of the proven radioiodine avid metabolic policy is required. So according to these guidelines for the carcinoma, either the papillary or other carcinoma, that can be helpful for the monitoring of this patient. So if we go for a diagnosis of Hashimoto thyroiditis, You can see here in a diffuse goiter the symptoms of hypothyroidism. There are some testing like antimicrosomals or TPO antibodies testing is required along with the thyroglobulin antibodies, anti-TG. So if these tests are negative, ultrasound and biopsies are recommended. And if these are negative, it should be considered as another disease. If these testings are negative and ultrasound and biopsies are positive, then you have to go for, physician will go for an further diagnosis for the Hashimoto thyroiditis. If these anti-TPO and anti-GG antibodies, both antibody testings are positive or one is positive, then it leads to the Hashimoto thyroiditis. So this is basically a diagnosis algorithm in case of diffuse goiter through the ultrasound and the signs and symptoms of hypothyroidism. They need to evaluate further for this disease. So if we talk about the competition with the SNIPE thyroglobulin versus the Roche, Abbott, and Siemens, we have an edge of 50 tests as compared to the usual routine 100 tests, because these are the niche markers whose workload is usually low in the labs. So they need to be run these assays on not on a regular basis. The principles are the sandwich principle competitions, and the competitive principles are available from the Roche, Siemens, and NTTG Abbott platforms. If we talk about the sample type, in the first generation, we evaluate the SNIPE thyroglobulin antibodies testing on just serum, while the other competitors, they have evaluated on both serum and plasma. If we talk about the sample volume, we have a just 10 microliter sample aspirating volume, which helps to check this disease in this with a minimum sample volume. The calibration stability for the first generation was the 2 weeks as compared to the 7 day, and the lot specific calibration, or if the 28 days are exceeding, if you are using the same lot, the onboard calibration stability of the thyroglobulin antibodies on Abbott platform is 28 days. While the Siemens is offering just a 14 days onboard stability, and we have a free of cost calibration and controls from this platform. If we talk about the reference ranges is less than 95, and the Roche has 115 and 4.11 from the thyroglobulin of Abbott, and 60 from the Siemens. So the linearity range is from 0.5 to 2800 on thyroglobulin SNIPE, and the Roche has an 4000 value, and they're even due to the reference range is 155. So it may not have a greater impact on the linearity results difference between the SNIPE and the Roche and the Abbott and Siemens versus. So if we talk about the test time, we have just 29 minutes assay time along with the Roche. They have offering an 18 minutes assays, but these are not the life saving tests. So it's for the prognosis purpose or for the monitoring purpose, for the screening purpose testing. That's why the 29 minutes are equally good as compared to the 18 minutes. If we talk about the traceability, according to the WHO first standardized reference material about 65, that is 093. We have an NIBSC standardization. So only the Roche and Siemens have this standardization against the anti-TG assays, while the TG anti-TG from the Abbott platform, it's also standardized against the WHO reference material of 65 by 93. So this is the comparison between the competitors and the SNIPE thyroglobulin. So as you know that we have a next generation thyroglobulin. So this next generation has an edge of 50 tests, minimum sample volume, calibration interval increase, free of cost calibration controls, and we have a linearity range along with the 29 minutes assay is equally good as compared to the first generation assays. So if we more talk about the other comparison key market player and the difference between the first generation and the second generation of thyroglobulin antibodies, we have equally good in the number of tests. We are offering 50 test pack size along with the 100 tests. The principle is sandwich, but in second generation, we have a plasma included along with the serum sample type, which was not recommended in the first generation. The sample volume is just 10 microliter. The onboard calibration stability is up to 28 days, which is equal to the Abbott, which has a recommendation of 28 days onboard calibration stability. So we have a free of cost calibrated controls with the first generation and second generation. We have a reference value of less than 95, the linearity between 0.5 to 2800, and we have a test time of 29 minutes. If we talk about the traceability, the WHO first international reference preparation is 65 by 093, and this is the comparison between the first generation and the second generation as well. So if we talk about the anti-TPO, as you know that the anti-TPO is a stand for anti-thyroid peroxidase. This basically is an enzyme which is used for the synthesis of the thyroid hormones, and it's also help as a catalyst for the iodine oxidation and the thyroglobulin iodination reaction in the thyroid glands. If you see here, this is an TPO function is to basically to stimulate it by the thyroid stimulating hormone, and then this TPO is a potential autoantigen. When it leaks from the inner to the outer of the cell, the anti-TPO antibodies will be produced. So the increase of anti-TPO can be seen in the autoimmune thyroid disease like Hashimoto disease. In the 90% cases, this is reported. In the Graves' disease, there are 75% of these cases have an increased value of anti-TG. If we talk about idiopathic and myxedema in the hypothyroidism cases, yes, and then also reported that this values of anti-TB is increased. So you can do that in this way. So if we talk about anti-TPO, which is also a marker for the thyroid dysfunction in the pregnancy, especially. As you know that according to the American Thyroid Association for the diagnosis and the management of the thyroid disease during the pregnancy and the postpartum, this is also a clinical utilization of the anti-TPO. So during this pregnancy, to check the thyroid dysfunction, there's an algorithm. If we go to this area, if to check the high risk woman who has a family history of autoimmune disease, and then they have a pregnancy, and they have to check the TSH as soon as the pregnancy confirms. So with the reflex testing, they have to go for a TPO antibodies if the TSH value is if the TSH value is between 2.5 and 10 mu per liter. So there are 4 different situations in which the high risk woman assessment for the thyroid dysfunction on the basis of routine TSH along with the anti-TPO. So in the first case, if the TSH value is less than 2.5 percentile or less than 0.1 micro unit per liter, then you have to see the thyroid toxicosis section. So if the value is between 0.1 to 2.5, it should be considered as a normal. She was on a high risk, but right now, no further investigation or workup is required. If the TSH values lies between 2.5 to 10 MIU and MU per liter, then the TPO antibodies need to be run. So this test clinical significance will increase when the thyroid stimulating hormone values during the pregnancy of the high-risk woman lies between the 2.5 to 10 MU per liter. So if the TPO antibodies, thyroid peroxidase antibodies are positive, then the probability of upper limit for the reference range is the 2.5 MIU, or then consider for the treatment with the levothyroxine. So the doctor will take the decision on the basis of this TSH value. If the TSH value is upper limit of the reference range and the 10 MU per liter, then treat with the levothyroxine. Or if the TPO value is negative and the TSH value between 2.5 and upper limit of the reference range, there is no treatment is required. But if the TPO antibodies is negative, but the TSH upper limit of the reference range is between upper reference range and the 10 value, then the consider treatment with the levothyroxine. So levothyroxine is also a very important role for the thyroid dysfunction treatment in the pregnant woman for the high risk woman. So if we compare with the other market players like Roche and Abbott, so you can see here, we have again the edge of small pack size because these are the niche parameters as compared to the other routine thyroid panel testing. So we have a sandwich principle, other have a competitive principle. We have validated the first generation on serum, while they both have generated the sample type of serum and plasma from these platforms. So if we talk about the sample volume, we have a 10 microliter sample volume. As compared to the other, they have a higher sample volume. The calibration interval was for the first generation was the 1 week, and the anti-TPO calibration stability was the 1 day, and new lot utilization or at 28 days, whichever comes first, is recommended by the Abbott. 28 days is the onboard stability of calibration curve, and the reagents recommended. If you are not able to consume the reagent of 100 tests on 28 days, you need to recalibrate the same reagent pack. So this is the quality recommendation guidelines from the Abbott platform, but we have in the first generation, the onboard calibration stability of 1 week. And then the calibrators and controls are free of cost, but they need to purchase additionally with the Roche and Abbott for the calibration of the anti-TPO. So we are equally good in the linearity and better in the higher side. So the less chances of diluted results in our case, or the wastage of the test to report of high results is very rare in our cases, because we have a measuring range of 0.3 to 1,000 international unit per ml as compared to the Roche, and Abbott has an equally good. So the test time they are offering in 18 minutes. We have a drawback of 31 minutes, which is higher than the Roche. But the SNIPE Abbott is equally comparable because the Abbott assay time for the anti-TPO is 29 minutes. Okay. So if we talk about the traceability, we have an standardized, again, the NIBSC standard material of 66/387, which has the National Institute of Biological Standards and Control of against that Roche and anti-TPO. So we are equally good in terms of traceability, linearity, and onboard stability. But in case of number of tests and the calibrator control FOC, we have an edge over the competitors. So you can see here we have an edge of calibration stability. In the next generation is the 28 days, which is the second generation assay as compared to the first generation. The first generation calibration stability was less as compared to the second generation, which shows you the onboard stability of 1 week. So if we talk about the NTTPO first generation and second generation, you can see that we have an impact size of 150 tests, which is ideal for those customers who wants to start these niche parameters for the improvement of the assay menu from the laboratory. So they have an equally good and new opportunity for introducing these assays. If we talk about the sandwich principle, both Harvard and sandwich procedures and the principle base, with the second generation is an improve of serum and plasma both, along with the sample volume is equally good with the first generation and second generation. But we have improved a calibration onboard stability of the assays 28 days, along with the free calibrators. And then there is improvement of reference ranges is less than 10 IU per ml, and the linearity range is between 1.0 to 1000 IU per ml. So the test time is 30 minutes on X8 and then 31 minutes on 4000. And we have on terms of accuracy, we have a traceability of a reference standard according to the global guidelines. Any question? So any question about the thyroid panel assays? If you have any question, you can ask me. Otherwise, we will go to the next slide.